future nurses! Welcome to Practical Nursing Pro, where we break down complex nursing concepts into easy-to-understand lessons. I'm Jade, your instructor, and today we're diving into a topic that appears on almost every NCLEX exam: fluid and electrolyte balance. This isn't just another boring lecture. In the next 25 minutes, we'll transform this challenging topic into something you can actually master. If fluid and electrolytes have been confusing you, you're in the right place. Before we start, let me walk you through what we'll cover today. We'll explore fluid compartments, sodium and potassium balance and imbalances, other important electrolytes like calcium, magnesium, and phosphorus. Then we'll work through NCLEX practice questions, test-taking strategies, and I'll tell you about some downloadable resources to help you study. If this is your first time here, make sure to hit subscribe and the notification bell so you don't miss our weekly NCLEX crash courses. Let's dive in. Fluid compartments. Let's start by understanding fluid compartments in the body. Think of the human body as an aquarium. Total body water makes up about 60% of your body weight. This water is distributed into two main compartments: intracellular fluid, or ICF, which is inside the cells and makes up about 40% of body weight, and extracellular fluid, or ECF, which is outside the cells and makes up about 20% of body weight. The extracellular fluid is further divided into interstitial fluid, which is between cells and makes up about 15% of body weight, and intravascular fluid, which is in the blood vessels and makes up about 5% of body weight. To help visualize this, imagine your body as an aquarium. The cells are like fish tanks within the aquarium, representing intracellular fluid in blue. The water surrounding these tanks is the extracellular fluid, which we can think of as green. Now, how does water move between these compartments? Through a process called osmosis, where water moves toward areas with higher concentration of solutes. Remember this key principle: where salt goes, water follows. Sodium is the primary determinant of extracellular fluid volume, while protein is the primary determinant of intracellular fluid volume. When assessing patients for fluid imbalances, look for these clinical signs. For extracellular excesses, you'll see edema, crackles in the lungs, and increased blood pressure. For extracellular deficits, look for poor skin turgor, dry mucous membranes, and thirst. Intracellular imbalances can cause cell swelling and confusion when in excess, or cell shrinkage and neurological changes when deficient. To help remember fluid distribution, use the ICE memory device. I stands for intracellular, inside cells. C stands for compartments, the separated spaces, and E stands for equilibrium, the balance between these spaces. ICE helps you remember fluid distribution. Now let's talk about sodium. The normal range for sodium is 135 to 145 milliequivalents per liter. Hyponatremia occurs when sodium levels fall below 135 milliequivalents per liter. Clinical manifestations include confusion, headache, nausea and vomiting, muscle cramps, and in severe cases, seizures or even coma. Let's look at a clinical scenario. Imagine a 68-year-old female presenting with confusion and mild seizure activity. Her labs show a sodium level of 126 milliequivalents per liter. This is a critical finding that requires immediate attention. What causes hyponatremia? We can categorize causes as dilutional, meaning too much water, or depletional, meaning too little sodium. Dilutional causes include SIADH, syndrome of inappropriate antidiuretic hormone, heart failure, excessive IV D5W, and psychogenic polydipsia. Depletional causes include diuretics, vomiting or diarrhea, adrenal insufficiency, and excessive sweating. On the other end of the spectrum is hypernatremia, which occurs when sodium exceeds 145 milliequivalents per liter. Clinical manifestations include thirst, dry and sticky mucous membranes, flushed skin, irritability, restlessness, and in severe cases, seizures. For treatment of sodium imbalances, Hyponatremia treatment includes fluid restriction for dilutional causes, sodium replacement for depletional causes, and 3% hypertonic saline for severe cases. For hypernatremia, treatment includes free water replacement, D5W or hypotonic solutions, and addressing the underlying cause. Moving on to potassium. The normal range for potassium is 3.5 to 5.0 milliequivalents per liter. Hypocalcemia occurs when potassium falls below 3.5 milliequivalents per liter. Clinical manifestations include muscle weakness, fatigue, cardiac arrhythmias, decreased bowel sounds, and flat T waves with U waves on ECG. Hyperkalemia occurs when potassium exceeds 5.0 milliequivalents per liter. Clinical manifestations include muscle weakness, paresthesia, nausea, vomiting, diarrhea, cardiac arrhythmias, and peaked T waves with widened QRS on ECG. Let's look at ECG changes in potassium imbalances. In a normal ECG, T waves have a normal appearance. In hypokalemia, you'll see flattened T waves and prominent U waves. In hyperkalemia, you'll observe peaked T waves, widened QRS complexes, and in severe cases, a sine wave pattern, which is a medical emergency. Many medications affect potassium levels. Those that increase potassium include ACE inhibitors, ARBs, potassium-sparing diuretics like spironolactone, NSAIDs, and beta blockers. Medications that decrease potassium include loop diuretics, thiazide diuretics, insulin, beta agonists, and corticosteroids. For emergency management of hyperkalemia, such as a potassium level of 6.8 milliequivalents per liter, priority interventions include notify the provider stat, continuous ECG monitoring, establishing IV access, and preparing medications like calcium gluconate for membrane stabilization, insulin with glucose to shift potassium into cells, sodium bicarbonate to also shift potassium into cells, and Kxalate to remove potassium via the gastrointestinal tract. Now let's discuss calcium. The normal range for calcium is 8.5 to 10.5 milligrams per deciliter. Hypocalcemia occurs when calcium falls below 8.5 milligrams per deciliter. Clinical manifestations include numbness and tingling, especially around the mouth, muscle cramps and spasms, tetany, positive Chvostek's sign, positive Trousseau's sign, and prolonged QT interval on ECG. Hypercalcemia occurs when calcium exceeds 10.5 milligrams per deciliter. Remember the saying, stones, bones, groans, and psychiatric overtones. Patients may experience kidney stones, bone pain, abdominal pain, confusion, and a shortened QT interval on ECG. Moving on to magnesium. The normal range for magnesium is 1.5 to 2.5 milligrams per deciliter. Hypomagnesemia occurs when magnesium falls below 1.5 milligrams per deciliter. Clinical manifestations include neuromuscular irritability, tremors, tetany, seizures, and cardiac arrhythmias. Hypermagnesemia occurs when magnesium exceeds 2.5 milligrams per deciliter. Clinical manifestations include hypotension, respiratory depression, decreased reflexes, cardiac conduction abnormalities, and CNS depression. Lastly, in our electrolyte review, let's talk about phosphorus. The normal range for phosphorus is 2.5 to 4.5 milligrams per deciliter. Hypophosphatemia occurs when phosphorus falls below 2.5 milligrams per deciliter. Clinical manifestations include muscle weakness, respiratory failure, confusion, paresthesias, and hemolytic anemia. Hyperphosphatemia occurs when phosphorus exceeds 4.5 milligrams per deciliter. It's often asymptomatic but can include hypocalcemia symptoms, soft tissue calcification, and is often associated with renal failure. Now let's work through some practice questions to apply what we've learned. Practice question number 1. A patient is admitted with severe hyponatremia, sodium 122 milliequivalents per liter. Which nursing assessment finding would you expect to observe? A. Hypotension. B. Seizure activity. C. Hyperreflexia. D. Increased urine output. Let's analyze. The correct answer is B. Seizure activity. Severe hyponatremia with sodium less than 125 milliequivalents per liter can cause cerebral edema, leading to neurological symptoms including seizures, confusion, and altered mental status. Let's look at the incorrect options. Hypotension is more common in volume depletion, not specifically hyponatremia. Hyperreflexia is more associated with calcium imbalances. Increased urine output contradicts the water retention typically seen in hyponatremia. Practice question number 2. A patient with hyperkalemia, potassium 6.5 milliequivalents per liter, is receiving emergency treatment. Which intervention should the nurse implement first? A. Administer sodium polystyrene sulfonate, or Kexalate. B. Administer calcium gluconate, IV. C. Start continuous cardiac monitoring. D. Obtain a 12-lead ECG. Take 60 seconds to think about this question. Let's analyze question number 2. The correct answer is C, Start continuous cardiac monitoring. Severe hyperkalemia can cause life-threatening cardiac arrhythmias. The first nursing action is to monitor cardiac status continuously to detect changes requiring immediate intervention. Looking at the incorrect options, Kexalate takes hours to work and is not a first-line emergency treatment. Calcium gluconate is important, but monitoring comes first. A 12-lead ECG is important, but continuous monitoring is a higher priority. Practice question number 3. A patient receiving IV furosemide therapy should be monitored for which electrolyte imbalance? A. Hypernatremia. B. Hypokalemia. C. Hypercalcemia. D. Hyperphosphatemia. Let's analyze question number 3. The correct answer is B, Hypokalemia. Furosemide is a loop diuretic that causes increased excretion of potassium in the urine, which can lead to hypokalemia. The incorrect options are hypernatremia. Loop diuretics can cause hyponatremia, not hypernatremia. Hypercalcemia. Loop diuretics increase calcium excretion, potentially causing hypocalcemia. Hyperphosphatemia. Loop diuretics increase phosphate excretion, not retention. Now let's talk about test-taking strategies for fluid and electrolyte questions on the NCLEX. I call this the NCLEX Survival Guide. First, use a decision tree approach for fluid imbalance questions. Step 1. Identify the imbalance. Is it excess or deficit? Step 2. Match the assessment findings to the imbalance. Step 3. Determine the appropriate interventions based on the imbalance. Next, learn to recognize lab value hotspots. Normal values are shown in green. Sodium 135 to 145. Potassium 3.5 to 5.0. Calcium 8.5 to 10.5. Magnesium 1.5 to 2.5. And phosphorus 2.5 to 4.5. Slight abnormals are shown in yellow. Sodium 130 to 134, or 146 to 150. Potassium 3.0 to 3.4, or 5.1 to 5.5. Critical values are shown in red. Sodium less than 130, or greater than 150. Potassium less than 3.0, or greater than 5.5. I also recommend using the WAVES approach for fluid and electrolyte questions. W stands for, what is the imbalance? Identify the problem. A stands for assessment findings. What would you see? V stands for vital signs affected. What changes would occur? E stands for eliminate wrong answers using lab values. S stands for safety first. Prioritize interventions. I've created a downloadable lab value cheat sheet featuring normal ranges highlighted, common medications affecting each electrolyte, clinical manifestations of imbalances, and priority nursing interventions. It is a resource to help you master this content. Coming next week, we'll cover acid-base balance and ABGs, the perfect companion to today's lesson on fluid and electrolytes. Before you go, here are your action steps. First, download today's cheat sheet. Second, subscribe for weekly NCLEX videos. Third, comment your #1 takeaway from today's lesson. What topic should we cover next in our crash course series? And fourth, share this with a nursing student who needs this information. Thank you so much for joining me today. Don't forget to download your free resources, and I'll see you in the next video.